Hello everybody, my name is Dr. Golzarian. I'm a internal medicine resident at St. Rita's Medical Center in Lima, Ohio, and I would like to give this presentation on a new proposed gold standard to accurately diagnosticate venous thoracic outlet syndrome. It is a pleasure for me to be here today and to give this presentation. It's a very exciting case and I do hope you guys will enjoy it. So venous thoracic outlet syndrome, also known as Paget-Schroeder syndrome, is a potentially critical condition that frequently arises secondary to anatomic abnormalities at the costoclavicular space, or the scalene triangle, or at the subcoracoid subpectoralis minor space. Special provocative tests such as the Adson's, Wright, or Roos are commonly used by clinicians to help diagnose arterial thoracic outlet syndrome, but unfortunately they are just not reliable enough for venous thoracic outlet syndrome. Venography is an effective tool that interventionalists may use to visualize the thrombus. However, even that still does very little in revealing the etiology of the compression, which in these patients is half the battle. So in this case, we demonstrate how the innovative utilization of these special provocative tests during the intervention can actually definitively determine mechanical obstructive etiologies. And this is crucial to the care of these patients, as they could require further follow-up urgent scalenectomy, resection of the first rib, and or circumferential venolysis. So we had a 21-year-old gentleman presented with a chief complaint of swelling and tenderness in his right upper extremity. His arm was turning blue, he said, after letting his significant other rest her head on his abducted shoulder for several hours overnight. And patient, unfortunately, he failed outpatient anticoagulation therapy with Eliquis, and his arm was getting only worse. So he was referred to us for evaluation and more definitive management. And by this time his entire arm was very purplish blue with prominent swelling and pain. We performed the Adson, Wright, and Roos tests in the clinic, and unfortunately they were negative as expected. And so we performed Doppler ultrasound, which then we found, again, that large subclavian occlusion still there, even larger than the previous one. We performed mechanical thrombectomy, followed by venoplasty with a 10mm semi-compliant balloon, and upon completion of this, we actually elected to leave the balloon partially inflated exactly where the thrombus was previously. We then had a member of our team reach underneath the sterile field and abduct our patient's arms and perform these provocative maneuvers, such as the Wright test and the Adson test. And surprisingly, it was clearly seen on the IV ultrasound and the fluoroscopy that the compression took place at the level of the first and second rib of the patient. And therefore, we were able to definitively determine the underlying etiology, and our patient was referred for rib resection, which permanently then resolved his issues. Diagnosis of thoracic outlet syndrome in general has always been one of exclusion, and it's based on thorough history taking, physical exam, and imaging. Special tests such as the Adsons, Wrights, and Roos have always been used by clinicians, but unfortunately they just remain very inaccurate tests with high false negative rates. So in this case, we were able to determine a venous thoracic outlet syndrome based on Doppler ultrasound, but then we were able to take it one step further and definitively determine the etiology. So we believe the use of an incompletely inflated balloon, or even the use of an IV ultrasound probe placed at the level of compression, coupled with provocative maneuvers in the middle of intervention, clearly, accurately, and even definitively provides the diagnosis and the etiology of the venous thoracic outlet syndrome. So this provides rationale and justification for seeking a definitive surgical therapy such as rib resection, as in our case, rather than just a temporary one such as thrombectomy or venoplasty. So in conclusion, the use of the Wright test or its modified variations during intervention with simultaneous IV ultrasound significantly increases the accuracy in determining the etiology of venous thoracic outlet syndrome. So as of now, the approaches to diagnosing and managing venous thoracic outlet syndrome remain very controversial and variable. However, we believe this approach has the potential to serve as the new gold standard. Additional studies will be needed to help validate this claim. Hope you guys enjoyed our wonderful case and have a wonderful rest of the day.